why don't we go through each of these steps in some detail, and then we're going to try to have everybody kind of think about how one might implement this in their own context. I've been involved utilizing this type of methodology for a couple of years now. We did an emergency medicine back in 2017 in my home school at Queen's at that time, and I've since applied it across 8 or 9 programs at Queen's postgrad, and now doing it across 15 or 16 programs via Royal College evaluation studies, and really acquiring a fair amount of detailed and kind of really granular specific data around the implementation of competency-based education. But I'm excited to think about using it in terms of any educational innovation. So try and think of it in your own context. So for step 1, how can we do this? So first step being establish your evaluation team. Do I have a slide for that? Yeah, sure. So who should be on the evaluation team? So I love Lego creatures. They're so fun. The evaluation team really is about finding the individuals for whom have a really substantial knowledge as it relates to the nature of the program and its intended implementation. Probably a combination of kind of very clinically minded individuals with individuals who are grounded in either science or the evaluation science or whatever it may be that you're implementing. In the case of competency-based education, we found teams to be very effective to have, of course, a program director that the program is being implemented in, perhaps even a competency-based education lead or competency committee chair, something like that, and then perhaps even having someone who represents one of the stakeholders that might be involved in the team might be useful. So in the case of CBME, this may be having a resident lead on the evaluation team. You may want to consider having somebody who is external to the training program specifically that innovation is being implemented in, to look at things from an external lens without the bias of being involved in that program for some time, being invested in that innovation in a substantial way, these kind of things. So it can be a broad team, can be quite heterogeneous in skill sets, and would be encouraged to be so. In the description of the program, I will always encourage people to consider kind of describing the program in a way that would allow any external or outsider to understand the nature of your program, the nature of the program that this innovation is being implemented in. And so if you are implementing a SIM innovation within a SIM training program, then this is where one would describe the kind of foundational elements of the SIM training program in general. If you are implementing across a whole national scale, a new curricular innovation across all, one of the subspecialty training programs in one of the family medicine AFC programs, we would want to describe the foundational elements of those programs. So whatever the scope and scale is, we want to describe the program in that level. For CBME, if you're implementing in a program, we would like to talk about our curriculum map and all the documents that go through the training program that this is being implemented in. And probably to allow the level of an elevator pitch around that training program, like, hey, tell me about your program. It would be useful for that. And then the last step in this would be describe the context. And I've always thought this is one of the most important moments in engaging in evaluation of an innovation, to describe the context in which it was implemented in. In the interest of shying away from doing another CBME example, I'll go to the SIM world, for example. So let's say we're implementing a new SIM curricular revision, and we're implementing it into a site, into a SIM site that has the following features. It has, limited funding for support. You can't get, for example, you're unable to pay for allied healthcare to help and participate. There is limited availability for time. There are very few faculty who are interested in engaging in it in the baseline. And the general culture within that institution is that it really feels that SIM is kind of not a useful activity, and they feel it detracts from learning. And historically, there's been challenges implementing simulation innovations within that site. That innovation sits on its own, but is being implemented in a context in which it will have a significant challenges that are less associated with the innovation itself and as much associated with the context in which it's being implemented in. And I think that same SIM program, that if it was implemented in a program that had a track record of innovation relating to simulation. Its residents and faculty were super keen on engaging there. It was well funded, well supported, and people had access to that all the time. And there was a natural culture which believed that this was a valuable activity. That same innovation may have entirely different outcomes down the road and an entirely different implementation. And a lot of that may be based just on the context alone. And so I bring this up as a critical step in the rapid evaluation process because it is inherent both for understanding challenges and successes and difficulties, but also in dissemination of findings subsequently of the evaluation work. So if we find that something behaved a certain way, we implemented X, and here's what happened. We really need to understand the context it was implemented in. And maybe I'm on a soapbox or something, but as a reviewer of lots of kind of recent evaluation work as it relates to CBME, often this element is missing. What was the cultural context this was implemented in? What was the support level that was provided? What were all these different elements that are necessary to understand something? So let's take a minute. So if everybody can take let's say 2 to 3 minutes and take 2 seconds and maybe describe either briefly the program. Now, hopefully I'll ask each of you to think about something that you're implementing or have implemented, some change you're involved in, any change that could be. And think of either taking a stab at describing the practical features of what it is that you're hoping to be implementing, or describe the context that that's being implemented in as a bit of an exercise. So why don't we each take 2 minutes? It's 1:43. Let's at 1:46. I'll get us to come back, and maybe if 1 or 2 people would be willing to share, that would be great. So we'll stop there for 2.5 minutes. Does anybody want to share what they reflected on in thinking about program and context, something that they would be considering evaluating in the near future or implementing in the near future, or have anything at all? I
can talk. We're in the process of, like many internal medicine programs, we're trying to implement a point of care ultrasound curriculum. It's not even agreement, I guess, within Canada or in the world about like exactly what an internist needs to know about ultrasound, but that's an evolving field that I think is actually not going to be the biggest problem. What I think has become the biggest challenge is actually contextual, in that we are working within a hospital system which is separate from a university that have conflicting interests, as well as different residency programs that have different resource constraints and expertise, to the point where I'm having like multiple hour-long meetings with our local, IT individuals about, subsets of different software that we might use to archive images, and it suggests that we are quite a bit further away from an actual educational program, just because we don't, like, the institution can't afford the software to archive the images. We don't have enough people trained up to do the training or the capacity to do it remotely. Like, all of these things are independent of what, like, the intellectual piece of, like, these are the foundations of ultrasound. These are the kind of windows and skills we want you to acquire. That part, I think there's a lot of examples that we could build off, but applying it in our setting is proving to be much more difficult than I had hoped.
So those would be super key features, and that's exactly it to look at when not just evaluating, but designing the implementation, where the phase you're at sounds like somewhere between soft implementing or trying to implement and understanding the features. Sounds very iterative, and that those contextual elements are going to be such a challenge to overcome, and will likely determine some successes and challenges moving forward, as much as the implementation of the innovation itself. It sounds like, so really well articulated. Anyone else have any other reflections on what they thought about or something they're implementing?
I thought about our CBD implementation. So yeah. Right now we have PGY 1 through 4 out of a total of 5 years who are in the CBD stream. So next year we'll have everybody in it, which will be nice. We've done sort of a combination of survey and focus groups to get at faculty and resident experiences with the implementation. And I think what we have found is that the lived experience is quite divergent from the ideal experience with CBD. And I think some of the challenge we're left with right now is how do we try and make those points come to where they're supposed to be together. So our residents feel that it has not necessarily improved the quality of feedback that they receive. You know, people who are going to give good feedback regardless of whether there's an EPA that they're working on, and have sort of structured assessment to anchor the feedback in. People from a faculty perspective feel like the residents are using EPAs more like a checklist. They're not actually interested in getting, you know, honest feedback on a daily basis. They're just sort of, you know, gaming the system to try and get as many things off their list as possible. And so as well, the other thing is, you know, having numbers inherent in all of the evaluation. So I need 5 of these, I need 6 of these, 3 of these. You know, what was meant to be a low stakes assessment strategy has become automatically this more like everything matters. You know, any EPA assessment I get that's not at least a 4 or a 5 doesn't count. So what's the point? And all of a sudden, like, there's this huge assessment burden that everybody seems to be facing. So if you have a solution for that, I would love to hear it.
Thanks, Michelle. My solution is right now, you are not alone. And as you saw off the hop, this is a pervasive signal and kind of a foundational, not foundation, but like a very strong signal across residency training programs across the country in the implementation, and a clear difficulty in the alignment between intended implementation and actual implementation. I don't think that there has been a program in the 20 plus programs that we've done deeper focus groups with trainees where there hasn't been some sense of this signal. The interesting thing about the signal is that I think is to tease out the driving features and what the driving features are across contexts, and diverging a little bit from the nature of where we're going in the talk. I think that there's probably multiple, and the more times we engage in processes like this to understand the experience, I think that next step now is, so we're hearing the experience, we're hearing the divergence. Can we tease apart what are the drivers of that? So is the burden of assessment because there is something wrong with the fundamental design of EPAs? Is the burden of assessment that there is something, a struggle in individual contexts to do with local cultures around assessment and teaching and competence decision making? Is there something wrong with assessment tools? Is there a struggle with e-portfolios and the way they provide information and data? What are the things that are driving the gaming of EPA assessments and the reductionism and the focusing on it as a checklist? And so I don't have an answer for you right now. Beyond that, I think that that's a strong signal across programs, and again, further divergence. So there's like large meetings about this burden of assessment happening at the college level across specialties and disciplines to understand this and to help figure out how to direct adaptation the right way. So we can, you'll hear more about this as we move through this, but it's interesting. If you reflect back on it, I would think locally, I would have a look and say, okay, let's think about the context that we've implemented CBME in and our implementation to say, what are the contextual features here? What is it about our training program? What were things like beforehand in our training program? What was the culture of assessment among our faculty prior to this implementation? What was the relationship between faculty, program leaders, and residents, and how that interplay of assessment and that happened ahead of time? How has it now changed with the implementation of CBME? And how has the impact of those contextual factors been on that? It is something we're seeing in some settings, but I would say that the experience, that burden of assessment, is heterogeneous and that it's not experienced in all settings. And so we're trying to now look and say, what is it about these settings where this is a major challenge? And what is it about these other settings where it doesn't seem to be a challenge? Okay, thanks, team. Let's move on. And Michelle, we'll come back to this probably a couple of times. So now we want to talk about how we would describe our anticipated outcomes. And so we've done the process of describing our context in our program, and we've put together a bit of a team to evaluate. And so we want to think about how we're going to actually describe our anticipated outcomes. It's helpful to rely on a bit of a framework sometimes. Any time we're engaging in an evaluation process, it's nice to utilize a framework of some kind to talk about our anticipated outcomes or anticipated goals. In the case of competency-based education, we use the core components framework, which I introduced a bit earlier, but is essentially a description of the key elements that should be present within a CBME program. In the case when we're doing this rapid evaluation for CBME, what we've been doing is describing it in a very granular way across stakeholders. So we've said, okay, if we're implementing CBME, what are our anticipated outcomes as it relates to three groups: our program leaders, our clinical faculty, and our trainees? And then what are the anticipated outcomes or behaviors as organized by those core components? I'll give an example of how this plays out in a second, but I want to generalize this a little bit. So Ken, if we think about you want to you're implementing a point of care ultrasound curriculum. And so how can we describe the anticipated outcomes of that? Well, you could still organize it by stakeholders. You could say, okay, so what are the anticipated outcomes for my faculty? This is what the point of care ultrasound curriculum training program system, this is what our clinical faculty should, these are the behaviors, these are the activities of my faculty within that program if we've implemented as intended. Similarly with the residents, with your trainees, you could say, my trainees will be engaging in teaching sections at X intervals. They will record their imagery within the following electronic imagery tracking system. That imagery tracking system will connect to the central hospital-based imagery tracking system and will be reviewed by quality control with the following individuals, et cetera, and not being a POCUS guy all that well. I'm going to butcher all those terms, but hopefully that makes sense to you. So considering some kind of a framework and then identifying the behaviors of our stakeholders and the anticipated behaviors of those stakeholders as it relates to that framework of outcomes. So for CBME, an example, okay, so what would I expect for my clinical faculty as it relates to teaching tailored to competencies, for example? I would say, okay, I anticipate my faculty will be directly observing residents and giving constructive feedback relevant to EPAs in their clinical context, that they'll provide training stage-appropriate supervision, understanding the concept of entrustment, and they'll teach within a CBME curriculum on shift, at rounds, in the sim lab, and in all other contexts. And so I can use that as my kind of explicit behaviors of my faculty that I'm hoping to have within that specific core component, and then can do that across all these different cells to describe the behaviors we'd be hoping for. I don't want this to sound like, the word behavior to me always sounds like and that's because I have tiny kids, but like it's like a punitive thing, like, oh, these are your behaviors. But instead, I would consider the concept of behaviors as this is what the activities and experiences of our stakeholders within the system, and what we'd be hoping that they would be doing. Questions about that? I mean, I know some of you aren't engaging in the CBME thing, and so this framework specifically may be less relevant. But I think being stakeholder specific in our anticipated outcomes is an important feature. And considering different ways to look at and organize those outcomes depending on what it is that you're implementing. So why don't we do this? First, any questions about these, but I think I'd like to give you guys the opportunity now to consider, okay, and what I'm implementing, what I would like to implement, or what I have implemented and hope to evaluate, what are my anticipated outcomes for this implementation? How would I kind of organize and articulate what the desired outcomes of my implementation may be? And so I just get everyone to take a few minutes, but to do this. And while people are writing and thinking, we can also answer questions. It's 1:58, maybe do 7 minutes. So at like 2:05, we'll start the large group back together.
Andrew, I could share an example. One of the things that we've implemented in the last few years in our program is a report that we provide to residents and preceptors at their portfolio review, which gives them an overview within a time frame we can specify of the number of patients that they've seen broken down into various categories. So breaking it down by gender and age of patients. This is in family medicine. Mm-hmm. And then breaking it down, highlighting using billing codes or diagnostic codes in OHIP. how many preventive healthcare visits they did, how many procedures they did, how much palliative care, home visits, certain chronic conditions like diabetes. And one of the reasons that we implemented this type of report for our residents was in response to questions and concerns by residents. Were they getting enough of certain things and too much of others? And our hope was that by providing residents and their preceptors with this information at portfolio reviews, it would give them something more concrete to make those assessments on than just their own perception. So what are the actual facts about who and how much you're seeing of various things? And our overall anticipated outcome was hoping that it would lead to truer identification of gaps and that it would enhance educational planning conversations. And I guess that's a little bit where I'm stuck, because not being an evaluation scientist, those outcomes feel a little trickier to me to measure. I mean, we can measure some of the concrete stats within the reports, but then how do we actually measure the outcomes that relate more to something broader and more conversational?
Yeah, that's a great one. That's where the lines between, I think, measuring and evaluating the fidelity of your implementation blur with kind of early short-term outcomes of the implementation, and the blurring of kind of outputs and outcomes. But I would suggest that probably starting with very proximal kind of elements from the implementation, or measuring the actual implementation itself, would be the most kind of useful endeavors. How often are trainees reviewing their reports? Are faculty engaging with trainees to review their reports? It might be interesting to say, if we went right back to this, the truest, the most fundamental parts of this methodology, the implementation wouldn't just be the portfolio reviews. The implementation would be, the portfolios. The implementation would be, yes, the generation of the portfolios, but how are they all to be used? And we'd want to document the kind of ideal ways that portfolio would ideally be used. So in my ideal implementation, I would generate this portfolio. My trainees would review it every 2 months. They would seek feedback from a coach or supervisor around the implications of that portfolio. They would reflect on it, and then they would alter their training experiences in response to that. So that might be kind of the desired implementation. And then you can go out and find out, okay, is that actually what's happening? And probably that's more important than going more distally now to say, okay, how is this affecting distal outcomes? Does it mean I'm making a better trainee? Well, that's a little bit beyond that. We can't just implement the portfolio and then say, is this portfolio making my trainee better at 10 years from now as a family doc, or 5 years from now, or 2 years from now? We probably want to look at the very proximal, is this actually being implemented as intended? Does that make sense, Heather?
That is so helpful. Yep. Thank you very much. It makes something that was feeling a bit tricky feel more concrete and manageable. Thanks so much.
Yeah, no problem. I mean, when it comes to outcomes measurement, I really think about things that, if anyone, now I'm in emergency medicine, so like resuscitation is in my brain all the time, but there's the chain of survival in CPR, and not CPR, but in cardiac arrest care, and there's all these early studies, like, does epinephrine get you to the hospital with a higher likelihood? That may not impact downstream survival, but it's going to get you to the hospital. And then so you have all these interventions at different little intervals throughout the process. And it's difficult to measure really long-term outcomes, but we're constantly measuring short, proximal, measurable outcomes from each one. And I think that that's a really critical thing to be doing when it comes to educational interventions. The first step being, as we're kind of really focusing on today, measuring the fidelity of that implementation and the integrity of that implementation. And then the next step, it can be blurred with the very short-term outcomes. And then once we have clearly demonstrated our fidelity of our implementation, we can start considering looking out from there. You can imagine that, to say I've implemented competence by design, and 5 years from now, just look at the quality of a doctor as a result. Well, that's going to be a really challenging thing to do. what defines the quality of a doctor? Starting with that alone, we got into specialty specific metrics. There's going to be debate and confusion about that. So we need to really look proximally to start demonstrating impact of things. Every med-ed journal has a room for innovations. And those innovation reports used to be, tell us what you did. And the innovation reports now are, tell us what you did and how you evaluate it in some way. And so I think this is where the home for that academic scholarship is. Funding element is another challenge altogether, but I think that's where the home for a lot of this is. And that is that a good innovation combined with a quality evaluation effort can live in an academic journal from those perspectives. Does that make sense? Yeah. Okay.
That does. That's really helpful. Thanks, Andrew.
No problem. Yeah.